Welcome to everybody. Welcome to the public meeting of NHS Tees Valley Clinical Commissioning Group. I can see that there's some faces that we don't see regularly, so I'll go around and get everybody to introduce themselves in order. So, in order that I've got on screen, Michelle Thompson.
Hi, I'm Michelle Thompson and I'm the lay member for Patient and Public Involvement for Tees Valley CCG.
Okay, Janet Walker.
Hi, I'm Dr. Janet Walker. I'm a GP in Middlesbrough and I'm Medical Director of the CCG.
I'm Bolesław Posmick, GP, salaried GP in Darlington and in Hartlepool, and the Clinical Chair of the Clinical Commissioning Group. Karen, able to come off mute? Yeah.
Sorry, I've got building works being done at the minute, so I couldn't hear the last time, so apologies. I'm Karen Hawkins. I'm the Commissioning Director for Primary and Community Care in the CCG.
Okay, TVCCG Corp Gov.
I think that's me, Pos. I'm Lynn Pearson, Corporate Secretary, and I'm taking the minutes today.
Thanks. Alistair Johnson.
Hi, I'm Alistair Johnston, one of the GPs in Ingleby and Thornaby, and a non-exec member of the governing body.
Okay, David Gallagher.
Hi everybody, I'm Dave Gallagher. I'm the Chief Officer for the CCG.
Okay, Nick Marco.
Yeah, I'm Nick Marco. I'm the local democracy reporter at the Hartlepool Mail.
Hi. Joanna Bushell.
Hello, I'm a clinical pharmacist and I'm a non-exec member of the governing body.
Jean Golightly.
Good afternoon, everybody. I'm Jean Golightly, Director of Nursing and Quality. Thank you.
Okay, Sprin P49. Oh, sorry, Sprin P, you're on mute. Everybody does it. Sorry, Sprin P, you're still on mute. You need to unclick the microphone icon on the bottom left. That's it, you're live now.
Finally, I'm Henny Spring, the Director of Public Health for Darlington.
Hi, welcome. Jackie Keane.
Good afternoon, everybody. I'm Jackie Keane, Head of Governance for the CCG.
Alex Sinclair.
Good afternoon, Alex Sinclair, Director of Commissioning Children and Young People for the CCG.
Thanks. Craig Blair.
Good afternoon, Craig Blair, Director of Commissioning for In-Hospital Services at the CCG.
Mark Adams.
Hello there, Mark Adams. I'm Director of Public Health for Middlesbrough and Raker and Cleveland.
James Neverson.
Hi, good afternoon. James Neverson. I'm a GP in Darlington and a non-executive member of the governing body.
David Emerton.
Hello, I'm David Emerton, Secondary Care Doctor on the governing body, which is a non-executive role.
Mark.
Hi, I'm Mark Pickering, Chief Finance Officer for the CCG.
Hey, Andy.
Hi, I'm Andy Mackay. I'm the independent member for the CCG.
Okay, and Caroline Gisham.
Hello, I'm Caroline Gitcham and I'm a lay member on the governing body of the CCG.
Okay, welcome all. We're definitely quorate now. As we can see, we've got Nick as our public person in attendance. And so, welcome all, and we'll proceed with the meeting. So, meeting is quorate, and I haven't had any other business notified. Does anybody want to raise any items for any other business? No? Okay. So, declarations of interest, we've got the attached sheets of declarations of interest, but there's also slight extra information in relation to declarations of interest. So for item 10, patient and public involvement update report, I'll need to read this, folks, there's a bit of it. The lay member for patient and public involvement is the Chief Executive of Healthwatch Darlington, and Healthwatch Darlington has received a grant from the CCG to deliver a small programme of engagement activity in Darlington on the CCG's behalf. The report does not make recommendations to commit any additional funding to organisations. The lay member is also a patient and public voice partner for NHS 6 and a non-voting member of the Northern Joint CCG Committee. Whilst these interests have been identified, they do not present a conflict and have ensured that the CCG benefits from the lay members' significant experience of communicating and engaging with local people. Okay, that's one. Next one, item 11, South Tees Carers Strategy 2021 to 2026. It's noted that governing body members working in general practice may have a non-direct professional interest in the aspects of the strategy that relates to working with general practice to support carers. This interest should not prevent members from receiving papers, participating in the discussion, or agreeing to recommend any changes in the draft strategy. And can I just check that would really just apply to GP governing body members, particularly working in the South Tees area? Is that correct? Yeah. Okay. So any other declarations of interest to raise? Just raise your hands visibly in front, because everybody's actually, I've got everybody on screen. That's my personal view as to the advantage of Zoom. Okay, thank you very much. So going on to the minutes of the previous meeting. So if you just bear with me a second while I scroll down to the minutes area of the sheets, plus the conflicts of interest. Okay, so going through the minutes, so this is page 9 in your pack starting. Okay, page 9, page 10, page 11, page 12, page 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, and there we go. So everybody happy with those, that they're a true and accurate record of the previous meeting? Nods around the virtual room. Okay, and actions arising from that. We had 2 actions, both dealing with the annual cycle of business and schedule of meetings, and they've both been completed. Okay, so any other items for the action log? No. Right, moving on to my report. So relatively short report. Interestingly, since we endeavoured to put as much out in the papers as possible, when I first did my report, it was sort of all sounding very nice in relation to lockdown and COVID, and that we were moving out of level 4 down to level 3, looking forward to hugs and so on. And then of note is basically that there's been the recent appearance of the COVID Indian variant around the country, which has been causing some concern. Fortunately, in our CCG area, it is not of particularly as high impact as it sadly is in some other areas of the country, but obviously it will be constantly carefully monitored, and updates will be provided to governing body members as and when, if needed, if the situation changes. Governing body working, we've started the governing body appraisal process. Myself and Dave, accountable officer, sorry, my TV is about to turn off. I can't let that happen because I'm using it for the for my big monitor screen to see everybody. So that started. Other governing body members, I'll just flag, I'm trying to use Microsoft 365 that the CCG has, which has some sort of process whereby you could book meetings properly. So I'll use that if possible to allow other governing body non-executive members to book their appraisals for the forthcoming year once it's been technically deglitched. But we look forward to getting a productive governing body appraisal process restarted so that we can carry on, particularly in relation to helping to develop our new governing body members who've joined us recently. Caroline, you've got your hand up.
Yeah, just for the record, folks, myself, Michelle and Andy did POS's appraisal, I think it was last week or the week before, just last week, was it? And he passed with flying colours. So thank you very much, everybody, for your feedback, because we did get a significant number of responses, and it was very positive. So thank you and well done, POS.
Thank you very much to everybody, and I'll encourage people when I'm doing other people's appraisals that I'll be sending out 360 feedback. If you could help with that for your other colleagues, it's very much appreciated, because it really does help to inform the discussion for people's appraisal for the forthcoming year. The governing body also took part, not all of the governing body, but as many as we could, into one of the sort of fairly regular sessions that Dave hosts for the staff of the CCG, of a strategic update for the staff to keep them updated as to what's happening in general CCG matters. And we effectively slightly took over that on behalf of the governing body to note and flag all of the work that the CCG staff have been carrying out, and the directors themselves and their directorates have been doing in relation to COVID over the last year. And I certainly found it very illuminating as to the sheer amount of stuff. I've kind of flagged a couple of things that in the report, but of note, 1 million items of PPE delivered as a result of CCG activity over the course of the last year, and up to 500 laptops to facilitate various people working out in the community, maintaining the services as far as possible. What's not in the chair's report is that we also then subsequently, not long after that meeting, had our councillor members meeting, which is on the agenda for James to actually present. But I'll just briefly mention that here, because I ended up having to chair that due to, I think, issues in relation to the fact that the volume of workload on primary care is really significant. I had a couple of other people scheduled to chair that meeting, but they weren't able to make it. There were GPs, working GPs, who were not able to make it at the time. But once again, at that council of members, we gave the directors of the CCG the opportunity to highlight to our member practices what had been done on their behalf by all of the people in the CCG, and the sort of level of work that if the CCG staff had not been doing it, would have actually landed on practices' laps directly at a time when the practices were having to deliver normal day-to-day care, but also then deliver all of the changes in work that had to happen as a result of COVID, and particularly delivering the practices' contribution to the COVID vaccination process. So that was a really useful opportunity for practices to get an insight into what was being done on their behalf by the hard work of all the CCG staff. So once again, I'll take the opportunity now, again, formally to thank the directors and all their staff for the work they put in to show us what they've been doing, but also thank the directors and all their staff for all of the work that they have been doing on behalf of the patients of the Tees Valley, to maintain day-to-day services as far as possible, and to flex their responses significantly in relation to the pressures that they've been facing as a result of the COVID situation. And the work has been entirely, highly admirable and very significant. So thank you very much. And I hope directors will once again pass on the governing body's thanks to themselves and all their staff for all of the work that they have done. Thank you very much, formally on behalf of the CCG. And then I'll shut up now and I'll give you an opportunity for any questions before we move on. No? Okay, thank you very much. And now moving on to Chief Officer's report. Over to you, Dave.
Thank you, Paz. I'll not go through this because hopefully it's fairly self-explanatory. Pick up on that reflection of looking back at the year. Inevitably, those sessions were never going to do justice to the amount of work that people have undertaken, but I think even just scratching the surface, it was humbling and actually filled us with pride with the amount of things that had been achieved. The section of my report on the integrated care systems I'll pick up later on in the agenda, but I would highlight the piece in there about the strategic board now between North Tees and South Tees Foundation Trusts. They've met twice now, so I attended the second one, and it's a really good start to the trusts working together, and not just on COVID recovery, but on recovery and how the FTs work closely together going forward, linking in with a clinical strategy. But the last bit probably to touch on is that apart from the systems working that we're doing, we're busy working now under the auspices of the staff group that Mark chairs to actually start to think about and get people back into the office working safely as the national restrictions reduce, and that inevitably will be a different way of working. You know, I don't think we'll be working from the office 5 days a week as people have been previously. And we need to give some serious thought to how many things we continue to do via Teams and Zoom and how many things we do face to face. So a lot of good work happening with that, but we'll see how that progresses over the next couple of weeks, and obviously we'll share with governing body how that's going to happen. And at some point, it would be nice if we could have a governing body meeting where we're actually in the room looking across tables with each other. We're just about there with some of the IT, but not quite. So watch this space.
Okay. Thank you very much. Any questions or comments from folks on that? No, moving on. So moving on to locality update, and over to you, Janet.
Thanks, Paz. Before the meeting today, I have caught up with our executive GPs who cover the broad geography of the Tees Valley. And I think one of the things that they were very keen that I did flag with the governing body today, which actually, Paz, you've already acknowledged, is how busy primary care is at the moment. And understandably, you know, all practices are working very, very hard to address the day-to-day demand that is certainly quite high at the moment, alongside the backlog, making sure that we can prioritise clinically those patients who have been waiting for treatment and services, and make sure that we can make sure that they are appropriately aware of what's happening with them and for them, but also alongside delivering the COVID vaccination programme. Across the Tees Valley, we are now up to 630,000 vaccines delivered, the vast majority of which has been delivered in PCN sites. We continue to have a focus on tackling vaccine inequalities to make sure that as we move through the cohorts, not only do we leave no one behind, but it's an evergreen offer that we can make that makes sure that, yes, you know, it can take some time for some people to feel ready to come forward for vaccination. So it's how we continue to offer it to them and make sure that our approaches are as accessible as they can be. And from a locality perspective, very delighted to report that we've had a variety of different innovative ways of trying to reach out to our communities, with pop-up approaches in mosques and community centres in Hartlepool, Middlesbrough and Stockton. We've had roving models for vaccinating the homeless into Middlesbrough. We had a model where the patients are transported into a centre in Darlington. We've had quiet clinics, especially for patients with learning disabilities in Darlington and in many of the other PCN areas as well. Trying to reach out into our communities in as many different ways as we're possibly able to do so. And vaccination rates are improving really, really well across all of the localities, which is pleasing to see. Obviously, sites are aware that we will need to consider moving into COVID boosters when we are more aware of what the campaign is going to require and need us to deliver. So it's ongoing work across all the localities, Pos. I think suffice it to say that there's been a lot in the press recently about general practice and the role of general practice in supporting the country's health, and some negative press about general practice. And I think from a CCG perspective, I wouldn't be reflecting what my colleagues are asking me to say if I don't acknowledge that it is exceptionally busy in primary care, but we need to continue to do what we can to meet the needs and demands of our populations across all the localities to make sure that primary care can make sure those patients feel supported with their current needs, as well as I said, addressing the backlogs with an especially continued focus around vaccine. Sorry, I'm obsessed with vaccines. Sorry, folks, with health inequalities to make sure that, yes, we don't allow COVID either now, currently, or into the future to widen our health inequalities that we have in place across Tees Valley.
Okay, thank you, Janet. Option for questions or comments from colleagues? Can I just check, Janet, that we're taking every opportunity that we can. You mentioned the harder to reach cohorts of patients for vaccine and also for general care during the COVID surge, that everything that we're taking all possible steps that we reasonably can to ensure that those harder to reach patients are being reached and that we're at least comparable to other areas in the Northeast?
No, thanks, Pat. I mean, a very sensible question to ask, and I'm delighted that we've got some of my partners from the DPHs actually on the governing body meeting today that will hopefully give testament to how we are trying to work together to make sure that we are all inclusive across the Tees Valley, making sure that we share our information as to what we have learned about the innovative approaches, what's worked well, what approaches are being used in other areas across the the integrated care system across the North East and North Cumbria, to make sure that if something, if there's a better approach, that we can potentially consider that or adopt that. And I have to say, yes, we are doing, we are performing very well comparative to our other areas across the North East and North Cumbria patch. And it will continue to be an evolving feast. We learn more on a day-to-day basis about different approaches that have been tried. We are looking forward to being able to use the Melissa Bus, which is a Health Education England funded initiative that enables us to take vaccine into communities with a different health facility, actually into the communities that may have greater difficulty accessing vaccine uptake, and that's going to be in place next week, for example. So there are many ways that we're working differently, exploring what's out there to make sure that we have that greater in reach. And it's not just obviously from a vaccine perspective. I'm sorry, I seem obsessed with vaccine at the moment, but from another health inequalities point of view, we know that from a population health management, there is a requirement for us to think differently about how we provide services into our communities. And forgive me, Mark and Penny, I'm sure will be able to contribute much more effectively on this from their authoritative positions. However, the PCNs are really embracing this, and there's some really good work that's happening at neighbourhood level as to how you can get that different approach that can have greater impact and greater benefits. Not necessarily a quick delivery of result and being able to evidence the change that you've got. Apart from vaccine, we can, because you can show you how your figures are increasing. I don't know if you'd want other members to contribute at that point, Paz, from possibly Penny or Mark.
Yeah, Penny and Mark, if you want to comment, give you an opportunity for a couple of minutes now. Mark first.
Yeah, I just support everything that Janet said about working closely together. We've mobilised the Melissa Bus with not very much notice to cover the shortfall. The Riverside Vaccination Centre is going to be closed for 9 or 10 days during the international matches, and we've mobilised more local provision, which I think will have a bigger impact on the health inequalities that we see. And I think my focus at the moment is on the over in Middlesbrough, there's 5,000 over 50s unvaccinated and 16,000 over 50s that have only had the first dose. So bearing in mind that the vaccine is 30% effective against the Indian variant, we have to consider that those people are at risk, and the increased transmissibility of the Indian variant will mean they're more likely to get found by the virus. So that's what we're trying to focus on locally. How do we ensure that the uptake, particularly of the over 50s, which is a little bit difficult because the national rollout is going lower and lower ages, but we're trying to focus that local provision on that group to minimise harm that the Indian variant could potentially do, and that's looking very worst case. But that's the work that we're doing, and I think it's been great actually to just see how effectively we've all been able to mobilise and just work together across organisational boundaries that might previously have prevented that sort of work. It's been kind of irrelevant of boundaries, and we've just worked together to try to get the best that we can for the people that we're trying to serve. I don't think there's a great deal more to add.
Thanks. Penny, if you want to comment at all. Oh, sorry, Penny, you're still on. That's it.
Finally, I'll get the hang of this eventually. Yes, just sort of leading on from Mark, in terms of Darlington, we're doing really well. With 97% of all those aged 70 or over now having received their first dose of the vaccine, and with 70% of all adults now having had at least one vaccine. So we're doing really well, but there's still a lot more that we can do, and we're going to look at particular strategies for encouraging our younger population to take the vaccine when they can, particularly those in their 30s who are being offered now. So that is working really well.
Okay.
And I'd like to say huge thanks to Janet, who's been absolutely fabulous in the vaccination response, and we're very grateful to have her.
Thank you very much. Okay, so any questions? Any other questions or comments? No, we'll move on to. I briefly touched on the council of members update. So a significant proportion of that meeting was spent on the CCG response to COVID. There was a brief update from Dave Gallagher to council of members as to ICS, Integrated Care System Development, and he'll be touching on that later in the agenda for governing body members anyway. This was also the opportunity for the council of members to formally respond to the draft annual report, which they had the opportunity to respond. There weren't any comments from the council of members on that. And there was also an opportunity for our council members to sort of feedback and hold the governing body to account. My only comment is basically echoing what Janet was saying, is the volume of workload in general practice that made it difficult, for the council members to have their own chair to hold us to account. But there's just the fact that the response and COVID recovery process now is also beginning to gather momentum to try to catch up with the backlog of routine planned care that needs to take place, or that had been sort of postponed to a degree during the COVID response. And it was the sort of feedback from practices in relation to how this works that we're taking on board to facilitate and smooth the process, to make sure that patients get whatever potential work or investigation needs done in the most appropriate place to get them back into the system as smoothly and safely as possible. Janet, you've got your hand up.
Yes, mainly with the right hand to raise this. I do beg your pardon. I had promised at the last meeting that I would update the governing body with regard to formal engagement with practices. Understandably, as we've acknowledged, it was great that the council members, some of them were able to come together last week, but recognising that the pressures of work are significant in general practice, we haven't formally met with member practices from an engagement point of view, but we will do that as and when the pressures allow us to do that, Pos.
Yes, thanks. Okay, thank you, Janet. So any questions or comments on the report or council members update? No hands up. So moving on to the patient and public involvement report, which got sent out as a separate paper. Michelle, certainly I got, so I think everybody else will have got. So over to you, Michelle.
Okay, thanks, Pos. So hopefully everybody's had a chance to read it. Sorry, it was a little bit late. So for external meetings and events, I've been attending quite a lot at a national and also a regional level, which has really helped me to understand the ever-changing NHS landscape and just how patients can get involved at various levels, but also how patients are also being supported in their own homes with new digital ways of working and support, such as hypertension. Understanding from an ICS level where perhaps patients need to be, patient representatives. Also with the CCG Joint Committee as well. I found that a really interesting development session. And again, it's just how everything is emerging across the Northeast and how people are working at a local level, and hopefully how that might continue going forward, but not watering down the patient voice. There's also the digital transformation work stream for the Tees Valley Integrated Care Partnership. Again, I find this really, really interesting because this is looking at different ways in which people's data can be used to improve services in the future, and making sure that we've got a trusted research and evaluation environment, which basically means just making sure that patients' information is safe, but can also be used by professionals to better patient care in the future. And then also from a patient and carer perspective, the referral system and the referral and advice pathways. I got invited to the Clinical Council for NHS for optimisation and improvement, and really it's just understanding that referral pathway between primary and secondary care, and where problems may present themselves for patients in accessing services. I've also been busy with working with NHS England and our CCG comms and engagement officer on the 3 patient groups across the Tees Valley. We found that really useful to have the NHS England support to facilitate discussions, and we're looking at a consistent approach across the Tees Valley to ensure that we have got a strong southern voice going forward. So it's just making sure that we're all on the same page with the 3 different host organisations for the Hartlepool and Stockton Health Ambassadors, the Darlington Community Council and the South Tees patient group. So I think it really helped our comms and engagement officer Jake to understand the different ways of working, but just making sure that we are including specific demographics across the area, and that they are very different. And then moving on to local health watch updates. Hopefully you'll have been able to read through these, because there's lots of the current projects and priorities that they're looking at, including the annual pulling together the annual reports across the Tees Valley. Also word on the street, especially GPs, vaccines and dentists. I mean, I think everything that is in this paper just shows the amount of pressure that the system is under at the moment and how that is affecting patients. But for every concern that there is there, I'm sure that there's some very wonderful stories as well about, you know, just how fantastic the services have been. So, you know, we've got to balance that out as well. But for Health Watch to be able to pick up these concerns and make the CCG aware of what is word on the street at the moment, if there is anything that you'd like to pick up, that the exec team would like to pick up with the various Health Watches, I'm sure they'd be able to provide you with more information if needed. And then on to the Health Watch England priorities and reports as well. There's quite a few items on their website, which I think, you know, make for great reading, but also an understanding of how the Health Watch network works and how it could work across the North East and North Cumbria in ensuring that patient voice is at the system level as well as place and neighbourhood. So I'm open for questions if anyone's got anything they'd like to ask me. It's quite a long paper, so apologies if there's 11 pages.
Dave?
Yeah, thanks, Paz. And it's a comment rather than a question, Michelle. Really helpful report. And I've taken the opportunity because I always find the patient stories very useful and help us keep an eye on what we need to be doing. I was in a regional meeting about primary care and primary care development last week, so I actually mentioned some of the themes there, and I've shared with them nationally in terms of some of the things that are emerging in terms of national policy and process as well. So always useful to have. And you're right, lots of really good stuff going on, but we need to be aware of things that aren't quite working or people perceive to be not quite working. So really helpful. Thank you.
Oh, thanks for that. And I think because I also sit at a national level, I can bring sort of the local concerns or information at that level, but also I can see it coming back down as well, and how, you know, especially with the remote monitoring, just how that's being led in our area. So it's quite a good conduit actually. So yeah, I'm glad it works for you too.
Okay, thanks. Hi, Karen. Alistair, if you got a personal message from me, that was meant to be to Karen. Karen's just joined us. For introduction, for those who don't know her, Karen's our lay audit rep. Okay. It's also just reminded me that I, once again, have missed the top line of my chair's sheet. There's the apologies from Hasanta here and Jessica Hollingsworth for this meeting that I forgot to mention at the earlier part. So if you take those down. Okay, I've got Karen, Janet, and Jean as the next people to go. So Karen, you first.
Thanks, Pos. Thanks, Michelle, in terms of the report. It really helps us in terms of shaping our comms messages. And I think it's really helpful also that you picked up around there's lots of good stuff happening as well as some of the word on the street. And I think that's helpful. Obviously, our GP practices, and as you've heard from members, are under significant pressure at the minute. And what we're trying to ensure is that there's key messages out to the public. There is still, at the moment, obviously, to ensure that practices are working in accordance with the public health measures and safety, that they're still implementing as they're expected to, the remote triage and patient navigation, to make sure that wherever possible that we avoid queues in reception areas of GP practices and waiting rooms. And that's not only to protect the staff, but to protect some of those vulnerable patients that are being seen face to face within the practices themselves. The practices have been advised to prioritise based on care and need, and particularly those who might have been waiting longer, and to make sure the navigation directs people to the most appropriate person within the team, so that it's not always necessarily a GP. They can see other members of the practice team, and through that remote triage they can see them a lot quicker than they would if they were waiting on a GP appointment. So we're continuing to push messages out to ensure that patients are aware of that, and that those messages are continuing to be provided to the public, because it is frustrating when you're trying to access healthcare and you perceive that there's some barriers in place. And we'll continue to work with our practices as they move through this process, and continue to send out the messages, which we have done through social media and through these meetings and other meetings, through our partner meetings, that primary care is still open. They've never closed through the pandemic. They've still been able to offer face-to-face consultation where that's clinically necessary. And your report really helps us in terms of shaping some of those messages. So thank you.
Thanks, Karen.
Janet?
To be fair, I think Karen said a lot of what I was going to raise about how important it is that we support patients to be aware that we are wanting to get them to the right service that's going to meet their needs, and that's under the standard operating procedure that the NHS requires us to operate under. And it is that broader primary care team with regard to, yes, GPs, but there's our senior nurse practitioners, our pharmacists in practice, our social prescribers, and a whole variety of other people who also make up that team to get the best, to get the best service for that patient. But I do understand there are significant frustrations out there with regard to some of the phone issues with regard to access to a practice because of the heightened demand, as well as patients contacting with a variety of queries. And it's how we support patients to get the best care in the most streamlined way to enable others to also be able to get through as well. And for patients to use digital services where they're able to do so, and they need self-care where that is an appropriate part of their management plan.
Exactly.
Thanks,
yeah,
Janet.
thanks, Janet.
Jean, and then I've got Alex, who can't raise a hand, but I'll come to you next after Jean.
Thanks, Pos. I just wanted to say thanks to Michelle and the wider sort of colleagues in terms of Health Watch and things like that. The reports don't always make for easy reading, even though that you're very good to give us a balanced perspective. However, they're extremely helpful because I think we know, and we routinely discuss in governing bodies, how we've always got the patients at the forefront of what we're trying to do. And some of the mechanisms that we have to work through and some of the considerations and constraints and everything like that, we do actually keep the patient at the centre of our thought. But what's so helpful about reports like this, is it reflects back to us how that lands with patients. So how that actually feels when, despite our best efforts, you know, what it's actually like to then navigate those systems, or, you know, our best efforts to get messages out and they don't actually land. So I think it's really helpful, and just thank you, because sometimes it's not easy messages to deliver. We are always grateful for them, genuinely grateful, because it's actually, you think, oh gosh, well, we'll do that slightly differently. So it's just really helpful to have that candid feedback, that this is how it felt for me on this day with this service. Might have felt different the next day for somebody else, but also it's what I think is really useful is you start to get themes and trends as well. Actually, we have got this right, isn't that great? Or no, we haven't landed this correctly yet, so let's carry on. So just thanks to Michelle and colleagues. Thank you.
Thank you.
Thanks, Jean. Yeah, and picking up the theme of trends, your report, Michelle, was mentioning some of the feedback in relation to COVID vaccination, and then you'll see later on in our agenda that there's on our report on complaints, and that was one of the significant items in relation to complaints received by the CCG. So, you know, your reports do really pick up themes nicely. Thank you. Alex, over to you.
Thanks, Buzz. Just to reiterate what others said, it's really helpful, Michelle, to have the feedback and see the range of reports that have been written. Just looking in particular at the Health Watch reports, there's one there from South Tees in terms of the impact of a neurodevelopmental pathway in South Tees, and just to inform members that that pathway will go live, scheduled to go live in September. This September, after successful rollout last September in Hartlepool and Stockton, and most recently in Darlington in March. And we are working with the Parent Carer Forum. We work with all the Parent Carer Forums, and we're working with the Parent Carer Forum in South Tees to ensure that there's clear comms and parent guide, so that they're absolutely clear about what the process is for referral and what information is required for referral. So just to give that assurance, thank you.
Okay, so thank you very much, Alex. Any other comments? No? Well, thank you very much for the report, Michelle. Generate a useful amount of discussion and feedback. Thank you. Okay, so moving on to the South Tees Carers strategy, and we've got Julie Bailey joining us to present that, I think, if that's right.
Thanks, Chair. So this is a new joint all-age strategy for carers developed by ourselves, the CCG, and the two local authorities in Middlesbrough, Redcar and Cleveland. It builds on some partnership work that took place a number of years ago between the CCG and Middlesbrough, but this is now the CCG working with the two local authorities, taking very much a collaborative approach, with the local authorities looking to commission a single service going forward for carers in Middlesbrough, Redcar and Cleveland. The strategy is built around the 5 themes in the National Strategy for Carers, but there has been considerable local engagement with a huge number of organisations supporting carers and carers themselves. Pre-lockdown, going back quite a while now, we started a face-to-face discussion in our boardroom, but more recently we've had 10 online virtual workshops with a number of different groups across Middlesbrough, Redcar and Cleveland, really just building some engagement, support and informing the direction of travel that's reflected in the strategy and the action plan. And that's been expertly independently facilitated by a local partner. I think the key areas for us, or the expectations for us as a CCG, although the strategy is more than that, is really us maintaining our commitment to ensuring that the views and experiences of carers are considered in our COVID recovery plans, that when we're commissioning and ensuring delivery of services, that we listen to the experience and the voice of carers, that we encourage and support primary care to adopt the national quality standards around support for carers, and identifying and connecting carers with support to prevent crisis, and leading by example really as an employer and an anchor institution in the local system in terms of looking after our employees who are also providing unpaid care. There's a comprehensive action plan, which you will have read. Definitely ambitious, but I think it's what's needed. The ask's reasonable and proportionate. And as I say, it's been very much driven by lots of conversations with local groups and individuals. The strategy has gone to the groups and local councils, the executive groups, and the Health and Wellbeing Executive Committee, who've indicated support and will oversee its implementation. So we're asking the governing body today if they would endorse and adapt this strategy, and then obviously take forward our role in its implementation.
Okay, thanks, Julie. Personally, it's certainly nice to see that there's quite a significant element on the unpaid carers and also young carers. Young carers particularly, it's very easy to forget. They've got a sort of a significant place in the system. Michelle.
I'd just like to say, Julie, I really enjoyed reading this paper and also the action plan as well. And it's really good to see that carers have been involved in it all. Yes, it is ambitious, but I'm hoping that especially for young carers that their voice is coming through loud and clear, because, you know, transitioning from child to adult is it can bring its challenges, but when you're a carer as well, sometimes you feel that those normal, you know, sort of aspirations of where, you know, going to college, going to uni and things like that, for a young carer, that can sometimes be, you know, out of reach or feel as if it's out of reach. So I really hope that going forward that especially the carers who don't feel that they are carers, that their voices, that they are recognised and that their voices are heard. But it's a really good document. So thanks. It's really good to see.
Thank you, Michelle. Caroline?
Yeah, just to reiterate a lot of what Michelle said, I enjoyed reading it. I thought it was a brilliant document. It was good to see the equality impact assessment done as well so thoroughly. You mentioned in it about GPs adopting this particular policy. I'm just wondering how will that go through the system?
Okay, Julie.
How do you mean, Caroline? How we'll sort of engage with our practices?
Just in terms of how that'll materialise. Will that need to go through the PCC?
I don't know. Good question. Karen might be able to advise on that. I think it will be for an individual practice, but it's certainly got a focus around quality. Is Karen able to give a view?
Sort of, promotion through the CCG's regular links with practices. Sorry, Julie?
Sorry, Paz, I couldn't hear you very well there.
Apologies. Yeah, so certainly via sort of promotion via the CCG's regular links with practices and making them aware. Now, one of the things that makes it more difficult to promote bigger ways of working at the moment between the CCG and our member practices is that partly because of COVID workload pressures, but partly because of actually just general meeting difficulties, is that we've not been really running the practice development sessions that we used to run, you know, almost on a quarterly basis previously. However, the fact that Zoom works well and allows practices to meet without having to spend significant amounts of time traveling to a meeting venue will make it easier to roll out. Now that hopefully come middle of June, things relax a bit more, then hopefully we'll be able to start pushing this sort of message out via our practice development sessions as well. Janet?
So I think Karen may be going to come in, but I think just following on from what you've said, it is true that in many practices they have a member of admin staff who actually have a responsibility for promoting awareness of carers in an individual practice, and because it is an important part of making sure that we offer support to our carers within a practice, to make sure that for COVID vaccination, for one thing, to be honest, that has given us a great need to make sure that we're more aware of who our carers in our practice, but also flu vaccination as well. And I think that piece of work will be ongoing, and I think it's how we feed all this wealth from the carer strategy into the practices across South Tees. But actually, to be fair, as Julie's emphasised in the report, it's how we spread that broader and wider as well.
Okay, thanks, Janet. Caroline, does that give you some assurance in relation to spreading the word into primary care?
Yeah, absolutely. Like I said, it's a great report and there's a lot of stuff in there. So I think the importance is in its implementation as always. So no, that's great to hear.
Right, thank you very much. Anybody else? Comments or questions? Alistair, I see you're off mute. Yeah.
Thanks for that, Julie. It's a nice piece of work. Just regarding, you do mention about linking with the PCNs in terms of rolling this out. I see the role of the GP being really useful in picking up new carers, maybe having standard codes and whatnot. But that's really useful. I worked in the Dales and Easington area, and they had just standardized carers packs that they just issued, and all the GPs were pretty much switched on. Not so much in Stockton area. So if you have a look amongst different sort of practices across the area, you might actually pick up some nice things which are quite scalable.
Thanks, Alistair. And that's prompted me to just mention one of the things that we've committed to is obviously this is very much a South Tees focused piece of work, but anything like that we think has benefit for carers across the whole of the Tees Valley, we'll be looking to work with our local authority colleagues wider than South Tees, but equally, like you say, to draw on that good practice that's out there as well.
Yeah, thanks. Yeah, certainly I echo the fact that this is one of the items where it's useful to work across a larger Tees Valley footprint for, if there's a good idea or initiative that we can pick it up across the Tees Valley. Thank you. Okay, on that basis, thank you very much, Julie. Very useful. And now moving on to, it's back to you again. Back to the Tees Valley CCG staff survey results and the action plan. Back to you, Julie.
Thank you. So this report that I know you'll all have had a chance to read summarises the results from the National Staff Survey for our staff and presents an accompanying action plan that responds to some of the key issues. And they're things that are maybe not being picked up by existing strands of work and have been developed in collaboration with staff. In most areas, our CCG was not significantly different to our peers, but I think the most important thing is just gaining that understanding of what this tells us about how it feels to be a member of staff in Tees Valley CCG and what that experience is. You'll note PICA, who the independent organisation we used to obtain and analyse the results, use the language of best and worst in comparison. It's probably not language I would use, but it's helpful to stick with that because it helps their results that they're prepared for us to make sense. Definitely not proposing to go through all of the results, but I guess some key highlights for me are around well-being, that we do have staff feeling that they still want to come in or need to come in when they're not feeling well enough, and this tends to be pressure they put on themselves rather than pressure experienced from elsewhere, and a number of staff that are reporting musculoskeletal problems, but we've got a Better Health at Work programme that will pick up some of that. With regards to managers, we seem to fare slightly less positively than peer CCGs. And we know we've had some support, a request for support by staff when we've been rolling out things like our wellbeing action plans, just to make sure the people line managing in the CCG are supported to have those conversations and have them in a helpful way. Morale and quality of care, staff, a number of staff do indicate that they would plan to leave. We don't know what the reason for that is. It may not be a bad thing. People might be moving on to new and exciting new opportunities. Unfortunately, the survey doesn't help us out with that. And I think given all the changes in recent years, however, it could be that staff are just feeling a little bit fatigued by all of the change. I think later on, one of the staff members in the free text talks about it's been quite exhausting, developing new relationships and partnerships. But on the positive side, many staff do feel their role absolutely makes a difference to local people. With regards to bullying, harassment and violence, very small numbers, but for us, we would take a zero tolerance approach to this. So that's something you'll see in the action plan. We've already started some conversations with our HR service around what we can put in place to offer some support and signposting for staff. Really positive responses around safety culture. Majority of staff agree that the CCG takes incidents seriously, it takes action when they occur, and staff feel really confident to speak up, which is good. With regards to staff engagement, Mixed views on staff's feeling able to contribute to the way work is done. Not everybody describes themselves as looking forward to coming to work, although I think that is an unusual question. But 3/4 of staff would recommend the CCG as a place to work. And as you'll see from some of the free text comments later, some really positive recent experience of changes to staff comms and engagement that have been implemented in the last year, suggesting that that's beginning to have a positive effect. New for this year was the experience of the pandemic. There was probably no surprises there, but it's just important to note that question was asked at the NHS generally and not necessarily just our CCG. Finally, we added some local questions around how it feels to work for the CCG, some positive feedback about the senior leadership team. 10 of the 11 people who chose to comment on this felt that it was really, really positive. And again, comms and engagement was much improved, but that ongoing plea from staff to help people stay connected with other teams, particularly while we're working remotely. And agile working was really a strong theme that came through as well. And we would expect that, and we know that many staff want to work in a flexible way going forward. And for the benefit of governing body members, there is a huge piece of work underway, engaging with staff around what a normal working week might look like when we do return to the office and how much flexibility there will be on offer, recognising the benefits to work-life balance. So that was kind of some of the key messages I've picked out. I know there's more in the report. The action plan at the end is structured around 4 sections, and they're the 4 sections the way the survey is presented to staff. So staff should be able to connect and see the feedback that they've provided, how it links with those key themes. So we're seeking support today to approve and progress with this work.
Okay, thank you, Julie. Certainly, the bit about the line where it says trust and value the staff, they work hard and go the extra mile. I think we've already sort of kind of formally acknowledged that, but you know, to stress that again, we absolutely do totally value our significantly trusted, excellent staff that we've got working with us. Okay, in the order that I've got you on screen, Dave, then David, then Mark. So Dave first.
Okay, thanks, Paz, and thanks, Julie, for sharing that and pulling together. These surveys are really important at the best of times. They're particularly important because of the COVID experience we've all had and learning from that, but also moving into a period of organisational change. So there's some really helpful stuff in there. Well, it's all helpful. There's some good stuff in there. Another staff group are working on to help us try and move forward with this, but it does give us a bit of a benchmark for ourselves, but also with other organisations that will help us navigate our way through the next few months. So really important, but it's really important that everybody realises how seriously we're taking this and getting the staff to come up with some of the views for how we move it forward. Thanks.
Thanks, Dave. David?
Thank you. Again, it's a very good report. The numbers in terms of bullying and harassment are small, only 4 or 5 members of staff, but we'd obviously prefer that to be 0. In the action plan, it's good that staff who've got concerns can seek support from other colleagues, etc. Just what about managers? Whether there's any feedback to managers of the sort of issue of bullying or perception of bullying, perhaps we should say, which it often is in practice, and how sort of managers can avoid that perception in the future.
Yeah, we've planned, David, to build that into a future staff event, maybe link it to the implementation of a more flexible approach to working, and, you know, kind of talking about what is and feels like micromanagement and how some of that might feel and be perceived. So that's how we're proposing to take some of that forward, and yeah, definitely raise some awareness.
Thanks.
Okay, thanks, Dave. Mark.
Dave mentioned the context of the organisational change and the fact that we've all been working in a pandemic, but it's worth noting the context that this is our first year as a newly merged CCG, which won't be the same for everybody else responding to this survey. So I think there's some really positive messages coming through this, taking into account the extra organisational change that we've been through that not everybody has.
Okay, thanks, Mark. Anybody else? Right, okay, so thank you, Julie. So we've considered the findings, and I'm sure we all support the actions proposed. Nods around the place, yeah. Okay, actually, it just reminds me, I didn't formally say that. Is everybody, in relation to the carers strategy, is everybody happy to approve the previous item, the carers strategy and the action plans subsequent to that? Yep, okay, that's for the record. Apologies for that, folks. Okay, now moving on to revenue budgets, and over to you, Mark.
Okay, thank you. So what I'd like to do is just take you through some of the highlights in the main report, and then just come back to the front sheet towards the end, and then take any questions, if that's okay.
Yeah.
So in terms of the paper, it's for the revenue budgets for the term of H1. So H1 refers to the first half of the year. So that's the financial plan for April through to September. The paper's here for review and approval. And what is attached is are three appendices. There's one which details the financial allocation. There's Appendix 2, which has the CCG budgets, and there's Appendix 3, which has the schema delegation. Similar to the last financial year, the arrangements are that the CCG is part of an integrated care partnership, and the funding comes down at that level. And what that means is that the CCG is operating effectively at three levels, as an individual organisation, as part of an integrated care partnership, so Tees Valley ICP, and also as part of the integrated care system. And there's a slide in the pack that shows how those three elements link together, but also is very clear that the system financial envelope that we have, so the funding we have, is at that integrated care partnership level. In terms of the funding envelope itself, it is there and it's adjusted for things like known pressures and policy priorities. Some of the arrangements for last year continue into the new year. So the block payment arrangements for our trusts continue. We don't have a normal contracting process with signed contracts. The values are set nationally, but there is scope for us to flex those locally where required. There's a level of inflation included, and we've worked through that, and at the moment the CCG plan as part of the ICP overall plan shows a small surplus for the wider ICP. One of the requests is to consider setting aside a contingency as a CCG. At this stage, the CCG hasn't been able to do that because we've deemed it unaffordable at this point. In terms of some of the assumptions we've made, we have assumed that we're going to hit the mental health investment standard, and that's a planned requirement from NHS England. We've assumed a level of increase in our cost for prescribing. We know that primary care delegated budgets, which the CCG has, have been under pressure in previous years, and that continues into the first half of this year. Any shortfall in that budget is covered through part of the core funding in the CCG, so it's included in these numbers. The Better Care Fund has quite a substantial increase at 5.3%. And as part of that, and working all of that through, the CCG's worked up some QIP or efficiencies required for the year, or the first half of the year, of around about £2.3 million, which is 0.37%. As I said, the CCG hasn't been able to set aside a contingency at this stage. So within the plan, there's a number of risks and mitigations that we've drawn out. Some of the main risks are around increases in costs that are unexpected, whether that's in prescribing particular drugs, for example, around diabetes or in CHC. There are costs around hospital discharge that aren't certain at this stage, but we are beginning to get some clarity on the arrangements for that. But also as part of our wider ICP, there are risks in terms of how elective recovery will pan out and whether there's opportunities for recovering additional funding on the back of that. In terms of the mitigations to those risks, one of the areas is the potential for funding I've mentioned around the elective recovery. And other than that, we would consider some of the more traditional measures around non-recurring slippage or issues around stretching our efficiency targets. One key point to draw out is that as an ICP, the four organisations that are in the ICP, so Tees Escambia Valley, North Tees Acute Trust and South Tees Acute Trust, and ourselves have worked collaboratively in terms of coming to that 0.4 million surplus arrangement. So as an individual CCG, we are in deficit, but as an ICP, we have a balanced position. The appendices that are attached show in Appendix 1 the level of funding that we have. So that amounts to £685 million, broken down helpfully, I think, between core CCG funding and that's held by the CCG but on behalf of the wider ICP. Now, those allocations include funding for general areas of growth and for some of the delegated budgets we mentioned, but also include some elements of spending on developments. Now, some of that is clear at this stage, but there is still some funding to come out for service development, and that provides an opportunity and a risk for us as we go forward in terms of understanding the requirements that go alongside that funding, but also seeing whether there may be some non-recurring slippage that we need to manage in year. There are elements that are outside of that funding to be confirmed. I mentioned about the hospital discharge programme as an example of that, and that's one area where as a CCG we'll be keeping a close eye on. But also included in there are some of the costs that are incurred by trusts for things like local vaccinations and testing. Appendix 2 sets out how we then use that money and what those revenue budgets will look like as a CCG, and that very clearly shows the shortfall or the in-year deficit for the CCG of around about 4.3 million. That's counteracted or balanced by the position across the 3 foundation trusts, which is a 4.7 million surplus, and that's where the 400,000 surplus is worked through. Appendix 3 finally shows the scheme of delegation out to the directors within the CCG, and it's a combination between the individual director and the CFO, which reflects the commissioning cycle really in terms of initial commissioning, ongoing review and recovery after that. So in summary, what we're asking for really is that the budgets are approved today. We know we haven't got all of the information. There's still some to come out in terms of the system development funding. We've highlighted the risks and the mitigations that are in there. And I'm not expecting any changes to this plan over the course of the next few weeks. But as that funding does start to flow through, we'll feed that in as part of our normal governing body finance updates. And as the months go on, we'd expect to get more clarity about what the term H2, as in October to March this financial year, and indeed some headline information about what 22-23 financial year looks like. So it's slightly strange in that we're operating in a bit of an information vacuum in terms of only knowing the first 6 months, but given the complexity and the volatility around some of the COVID response, I think we can operate within that for now and provide updates as and when that becomes available. So happy to pause there and take any questions, Pos.
Thank you, Mark. Can everybody hear me okay now? It's been a bit of a problem until now. Right, okay, apologies for that. David.
Thanks, Mark. A very clear report. You refer to help from foundation trusts for restoring the balance. I'm aware that South Tees has got a large historic debt. Will there be any sort of claims on any surplus they might have to go towards a historic debt at all, which could endanger our position of balance?
I think all of the 3 trusts have worked through the position for this first 6 months of the year, and all of them are in slightly different positions. At this stage, the focus is on this 6-month period. So until we know what the funding looks like for the rest of the year, that's the extent of this plan so far. Your question, I think, would refer to what happens in terms of the underlying position for those organisations. And I think that will come out as we get further through the year, looking at the second half and perhaps into 22-23, David.
Thank you.
Okay, thank you. Anybody else? Any queries or comments? No. So in summary, we're using all of our funds that we have available for direct commissioned care, apart from what you alluded to in relation to running costs and things like that.
Yeah, absolutely right. So we're committing all of our resource as a system The system is in balance. The CCG as an individual organisation is not in balance in terms of this initial 6-month plan, but we will keep that position under review as part of our collaborative working and see how H2, as in the second half of the year, starts to pan out.
Okay, thank you very much, Mark. Okay, thank you very much. Nice and clear, easy to understand financial presentation. That's enjoy those. Right, thank you very much. Now, moving on from revenue budgets. So we need to approve the financial plan. Is that correct? Formally approve that? Yep. So everybody happy to approve that financial plan? Yep. And we support the distribution of the monies, and we note the risks and mitigations that have been highlighted by yourself. Okay, and later updates to us as and when. Right, now moving on to corporate objectives. Jackie Keane, and I'm going to turn my phone off again. Sorry, over to you, Jackie.
Thanks, Chair. The brief paper outlines the draft corporate objectives for the CCG, which have been put together, as you know, following work with the governing body at the development sessions in February and April. We subsequently then sent them round to staff and asked for staff's comments. We received a few comments from them that have been incorporated in the draft that you've got with you. So those comments were to change the reference to being a good employer to being an aspiring to be an excellent employer. The addition of safeguarding as a high profile statutory duty, and also the staff supported the way that we've tried to highlight key elements of each of the objectives to make them easier to remember really, and then a bit more meaningful. So they're here with you today for approval, following which we'll be doing some additional work to look at and trying to identify measures of success, and also translate these into look at the way that the risk register is established as well, and translate that through to some of our operational processes. So happy to take any questions.
Okay, any questions or comments, Dave?
Yeah, thanks, Buzz. Thanks, Jackie. And worth reflecting on the fact that staff have had the feed into this, which was great. And actually, the bit for it being an excellent employer works for me, so I'm glad they put that in there. In addition to the bits and pieces that Jackie's described, we're also now starting to weave these into individual objectives as well as we cascade objectives down. So we will have a golden thread all the way back from what each individual does to how that has an impact on the corporate objectives and therefore the organisation. So if we agree these today, we can really crack on with that piece of work.
Okay, thanks, Dave. Caroline?
Yeah, I just think you've done a great job on these, Jackie. I think the sum it up and they are really clear. So well done. That looks great.
Okay, obviously, just to add there, that was a team effort, and Julie was involved in this beforehand. I wouldn't, just because I'm presenting it, I wouldn't want to take all the credit.
Okay.
Absolutely. Okay, so we approve and support the objectives. Do you need anything else from us, Jackie? No? Everybody happy with those objectives? Nods all round? Yep. Okay. Thank you very much. Moving on, governing body to look at the Stockton-on-Tees local area SEND special educational needs. Am I correct? Strategy. Alex. Still on mute, I'm afraid. Yeah, that's it. You got it.
Struggling to come off mute, and it's lost the page, but I'm nearly there. 2 seconds. If you just bear with me.
That's all right. Don't worry. It takes a while to move around the paper block on the.
Can you hear me fine?
Online. Yeah, but
okay, sorry about that.
Else okay?
So yeah, thank you, Claude. This is the SEND strategy for Stockton-on-Tees local area for decision today. Just to highlight that this strategy has been developed jointly by Stockton Council, ourselves, and key involvement of Parent Carer Forum. It outlines our local area commitment to have the best possible outcomes and to be successful, children to be successful, happy adults. It's been a journey that we've been on since the local area inspection in 2019. And the strategy itself is informed by the self-evaluation and our joint strategic needs assessment, and also ongoing consultation, engagement and co-production with parent care forum and the families and children themselves. There's 6 key priorities in the strategy: working in partnership with families, understanding the needs, developing a system which meets needs, and also is accountable for improving outcomes. Also ensuring that needs can be met in local mainstream schools, and that we have developed local specialist provision. And finally, so that children and young people achieve their potential and ambitions and can live as independently as possible. So there'll be an action plan that is developed as a part of this strategy. And you can see in section 6 that there is a governance structure to develop and monitor the action plan. The strategy went to the Health and Wellbeing Board on the 19th of May and got a lot of positive comments. And one of the key things through this, which we discussed at our exec and which was also highlighted at the Health and Wellbeing Board and to highlight today, is the fact that it's been acknowledged about the significant amount of parent care involvement in the development of this strategy. It's been done with them right from the beginning, all the way through, and they are also involved in the monitoring of the strategy as well. Thank you.
Okay, thank you. So, any queries, comments, questions, David?
Thank you. It's just on the first document. I don't think it actually says anywhere on the first document what SEND stands for. So that should just be at the beginning, just so that is understandable as a standalone document.
Yeah. Okay.
Thanks.
Yeah.
Okay. It seems so sort of self-contained and sensible, and it's very nice to be assured that the parents were involved very closely in developing this document, which I think is, self-evidently crucial to do when you're creating something like this. Okay, so we're asked to approve that document, is that correct? And support it? Yep. So everybody happy with that? Yep. Okay. Anything else you need from us for that, Alex?
No, thanks, Paul. And I'll just make sure it's fed back to the local authority, David's comment about spelling SEND in full. Thank you.
Yeah. Okay. Well, thank you very much. This is our now break for 10 minutes. We're running slightly ahead of schedule for once, amazingly. See you again at past or just after past. Opportunity for a refresher. See you, folks. I'll make sure my phone's properly switched off this time. I'll pull the plug. Okie dokie. I think we might as well get started. Keep running to as closely to time as possible. Okay, Dave, so over to yourself and Integrated Care System, ICS, update.
Okay, thank you, Pos. And I think Lynn's going to share the screen. I've just got a couple of slides to talk through with this. I suppose, first of all, apologies, I would have preferred to bring a written paper, but in the interests of keeping this as contemporary as possible, thought it might be worth just using some slides, but we will bring some formal papers once we've got a bit more information to the governing body.
Just bear with me, Dave. I'm just trying to locate my desktop. Hang on, whilst recording. Hang on, there we go.
That's brilliant, thank you.
Has that come through okay?
We've got your Internet Explorer screen at the moment.
Has it not come through with the slides at all?
No, there's sometimes a delay.
Right, okay.
Your focus is still on not Internet Explorer, File Explorer.
It's okay.
Has it come through at all? No.
No, I'll just talk to them. It's fine. We can send the slides out later on, or they might catch up because I think there's sometimes a delay. Lynn, thank you.
No problem.
Okay, so what I wanted to do this afternoon is just bring us all up to speed with where we're at in terms of all things integrated care and the white paper, some of the national planning timelines, some of the current thinking, and that includes some of the current thinking locally, and then just some of the issues that we've got that we'll build upon as we bring more papers to the governing body. So just as a reminder for everybody, the white paper talked about a number of things, and this is a paper that's going through Parliament as a bill that will become an act once it gets royal session. It talks about formally merging NHSE and NHSI. It talks about the integrated care systems across England becoming statutory NHS bodies from April 2022, and for those ICSs to take on the functions of CCGs wholly, and some of the commissioning functions from NHS England. Those commissioning functions are things like primary care, and that's all primary care, not just general practice. It's also dental, it's pharmacy, and it's optometry. And some of the other direct commissioning that NHS England do, including potentially some or all of specialised services commissioning. It also talks about relaxing some of the competition and procurement rules that the NHS has had to live with. It talks about NHS providers working together in at least one collaborative, so that you get providers working together. And it also talks a lot about enhancing clinical and professional leadership, and I think some of that's about not throwing babies out with bathwater in terms of some of the learning and some of the really good experiences we've all had with CCGs over the last few years, to make sure a lot of that carries forward. So the national timescales, and these are in the planning guidance, so it's published nationally. By the end of this quarter, all ICSs are asked to update and confirm the boundaries that they're working on, the partner organisations that make up the ICS, and how we'll work at place. I'll come on to place in a moment. By the end of quarter two, they need to confirm the designate appointments to some of the key positions, notably the chair of the ICS and the chief executive of the ICS, and confirm the proposed arrangements for working in shadow form. And that has an impact on CCGs, particularly because as we get into the second half of the year, and I'm just thinking about Mark's description of the finance with H1 and H2, as we get into H2, we'll need to be working more closely with other CCGs and preparing to work in shadow form, and indeed to hand over our responsibility safely to the ICS, which will be the successor body. By the end of quarter four, so that's the end of this year, all the appointments will need to be confirmed for the senior ICS roles. We'll have need to complete due diligence and preparations for staff transfer into the ICS, but also for property transfers. And indeed, there's a huge technical piece of work to move all contracts and things across ICSs that will keep us busy for a little while. And then there's a bit about having a signed off constitution. So just as CCGs have constitutions, the ICSs will need to have constitutions signed off by NHSE and I, with a view to 1st of April moving into the new way of working. So that's the national side of things. The current thinking locally, and that's within the North Cumbria North East ICS, is that we'd build on what we've got there already. So we've already got 11 foundation trusts. They're all working at the moment on a provider collaborative across North Cumbria, the North East, but I think there'll be an expectation that they work on more local provider collaboratives. Certainly the two mental health trusts in the North East do work on those two footprints and are starting to work with other partners in their areas. There's much said about focusing on working at place. So place for the ICS is 13 local authorities and their health and wellbeing boards. For us in Tees Valley, that's obviously the 5 local authorities, but also the combined authority that is coterminous with the CCG arrangement at the moment. And some thinking being done about how you'd work and agree partnership arrangements for working at that level, and indeed expecting some national guidance on how you work locally at place and what the deal is there in terms of responsibilities, accountabilities, etc. But from a Tees Valley perspective, I think we're well set up for this. We just need to get into the detail about how it does work. and crucially how we do things like make sure the clinical voice is heard from primary and secondary care, how patient voice, which Michelle's quite rightly mentioned earlier on, is heard as part of this, but also how we plug our 14 primary care networks into place. And obviously in Darlington, for example, that's relatively easy because there's one primary care network, one council, one place, if you like. A bit different in other areas that we'll need to have a look at, but also how we make sure that the primary care networks work together at scale, bearing in mind there'd be one of a huge number across Cumbria and the North East. So lots of things to think through and work through. Some of the challenges that we've got in that are the clarity in this, and the clarity's helped, or will be helped rather, by two things. One, there's a plethora of national guidance anticipated to arrive in the next month or so that will give some view on exactly what needs to happen and where it needs to happen and by when. There's also some clarity being produced locally where the organisations within the ICS are starting to put together now a detailed plan that picks up the work that needs to be done to get to the 1st of April and then probably beyond. And certainly in my head, so this is just my thoughts, there's a bit about work that we need to do now, work that needs to be done for the 1st of April, and then some of the work, which is probably some more transformational work, which goes on into next year and beyond. But I think the local plan that we've got colleagues working on at the moment will give some indication of what needs to happen, who's involved with it, which is most important, and also how we pull people in to contribute to that. And it's probably divided into transactional and transformational. So the transactional is the nitty-gritty of the huge amount of contracts that all 8 CCGs have got with various organisations. Will need to novate over to the ICS, which will be the contract holder at that end of the system, and how that actually works. And that's not just with the big FTs, it's all of the local contracts that we've got, including contracts with third sector providers, with local authorities, etc. So lots of work to be done on that. And the transformational bit's probably a bit about how we make best use of and exploit the opportunity of ICSs and working at place to do things a little bit differently and probably streamline things. So quite a bit of thinking needs to be done on that, but it's actually underway. The parliamentary process is the bit that's acting as a bit of a brake on some of this, because until it becomes an act and has gone through Parliament, some of the things that require legislation can't happen. So there's a bit about getting things teed up as best we can, but also there's a bit of reticence to go too far in case we suddenly have to make a U-turn and come back. Now that happened to a degree with the Lansley reforms that set up CCGs, among other things, but I think there's a recognition that it's less likely this time that there'll be any fundamental changes in terms of what goes into the parliamentary system. It's likely what comes out will be very, very similar to it. One of the big things that's really important in amongst this is communication engagement. For us as a CCG, particularly for our staff who are affected by this, because if you take the notion of CCG functions being completely absorbed by ICSs, there's a piece of work that will need to take place to transfer CCG staff and their functions into the ICS, and we're waiting for some HR guidance on that, but there's quite a bit of work to do there. So a bit of technical work to be done, but also some other work in terms of transformation. From a CCG perspective across Cumbria and the North East, we've set up a group of lead directors with input from each of the CCGs. So we've got Craig and we've got Mark feeding into that, and that'll be part of the engine room to do some of the CCG side of the business. But obviously there's a whole lot more to be done on this. So that's probably a bit of an update where we are at this point in time. Lots more work to be done. We'll pick it up in our workshop sessions as well as a governing body, and we'll work with the joint committee, which will have a role in this as well, I think, for the CCGs. But we'll bring formal papers back as and when the time is right to do that, Pos. I'll probably stop there. Happy to take any comments or questions that I shall try and answer.
Right, thanks, Dave. Yeah, so it still is a waiting game to an extent, but the time that we're going to be going into or the ICS is going to be going into shadow form, is now beginning to approach sort of focusing minds a bit. So, Andy.
Yeah, I mean, it's interesting to get the update. I'm just concerned, are we confident that everything that's got to be done in those timescales is achievable? Because it sounds like a huge piece of work alongside running the system as it would normally go. Are we confident we can do that, Dave?
Well, that's why I make the point about there's some stuff that can happen now, because it's probably quick fix stuff. There's some stuff for the 1st of April. And I think we'll just need to take a pragmatic view, Andy, on some of the stuff that actually we get across the line, if that's the right way to describe it, 1st of April, and then move on beyond there and do the developmental work. So if we work on the premise that this is probably not the right language, we just shift CCGs into the ICS and continue as we have been doing, then there's a lot less work required to do that for the 1st of April. The key to, I think, to be fair, is having that programme plan, and then we can assess the risk of that. These aren't conversations that we're just having locally. It's a national issue, as you'd understand. So we're probably trying to come all this together. The rate limiting factor is, though, it going through Parliament, and any further delay would have an impact on that, absolutely. We just need to see how that plays through.
Okay, thank you.
Okay, thanks. Anybody else? Any comments? Yeah, it's all work in progress, and at least we do have the opportunity during the developmental sessions to get updates, and also during our informal governing body meetings as well. Okay, so thanks, Dave. So we need your update, and moving on, learning disabilities mortality review. Over to you, Jean.
Thanks, Pos. So what you've got is the leader, as we tend to call it, which is the Learning Disabilities Mortality Review, as you said, our local area annual report. For colleagues who might think, oh gosh, this has come round again rather quickly, we did have the previous year presented at the back end of last year. So actually this shows us ahead in the annual cycle of business. I'm not proposing to go through it. A couple of key points I'd really like to emphasise, and I think the first one is the acknowledgement. You can see that key reminder to thank you to the family members, the carers, as well as the reviewers and the providers of service. We do this in conjunction, and we do it to learn, to make life better for our patients, but also those family members and carers around them as well. So just a bit of background as to why we do it. In terms of, it was identified that people with learning disabilities, there's quite a strong evidence basis that they have a high likelihood of a premature death. So this is to identify key themes that are amenable to improvement and to get on and improve those. It is underpinned now by policy guidance, but Tees Valley CCG and its predecessors, together with a number of other CCGs in the region, picked this up in the early days and ran with it because we felt it was something important to do. And the rest of so we were part of the pilot works around this. There's a lot of information in the report, and again, I'm not proposing to go through it all, but the purpose is to look for areas for improvement. That's really what we're wanting to do, and to feed that into the system. We've had, and that's feed into the local system, but also feed into the national system, because you can see Public Health England also do a lot of work in this area. A lot of tables and findings, but some key areas are under 5.2, which is the good practice is the predominant factor, which is always nice to see, but also there's plenty there in terms of room for improvement. Now, if you look at the annual health checks and the health action planning, this is something that Tees Valley CCG colleagues in primary care have made substantial strides with over recent years. And that's in part due to Pam McNeath, our clinical lead for learning disabilities. That's actually the primary care colleagues who deliver these annual health cycles, annual health checks, and also Mike Brealey and his mental health and learning disabilities team So it's a very cohesive team that is pushing this agenda for improvement, as well as the day job. One or two other things. Wanted to talk to you about end-of-life care. Now, that's never an easy subject for any patient or family member, but I think that there's a lot of work being done in meeting there's the same needs, but also there are often differing needs as well for learning disabilities patients and their families at this point. So there's a sensitivity there. One size doesn't fit all. And in terms of the Mental Capacity Act, we've got that value of the continuous approach to improvement. So I'm just trying to check if there's any other. We do have under the achievements to date, we do have a service improvement group that has previously been led by Alison Pivo. With her retirement, that's going to be picked up by Pam McNeice. As I said, she is our clinical lead for learning disabilities. So that good work that happens as a multi-agency, multidisciplinary footprint across Tees Valley will continue. And just ask you to note really for information. Happy to take any comments or anything, Chair.
Okay, thank you, Jean. Any comments or queries? Was there any learnings for us to particularly pick up in relation to COVID care, particularly noting the fact that COVID was more likely to be a cause of death than the average population in the learning disabilities cohort?
Yeah, that's definitely had a significant impact on the numbers. And if you look in the report, it does talk about it. And we also talk about the impact of COVID on the scheme, as in the reviewing of any deaths associated either with COVID or anything, but where the patient had a learning disabilities diagnosis. We did keep going throughout all the COVID restrictions, such as the value of this work. But obviously, you would expect to see a spike in the numbers, and we have.
Yeah. Okay, thank you. Caroline?
Just wanted to say I thought it was a great report. It was good to see good practice at the top. I know that lack of physical health monitoring has popped up elsewhere in other reports that I've seen. And there was some really good examples of good practice where they were getting significant numbers through in comparison to some of the others. But I thought that was a great report, and I'm assured to see the detail in there. So thanks, Jean.
Yeah, it's a challenge because each of these patients comes with their individual needs, and this is where it's hats off to primary care colleagues who flex and accommodate and flex again to ensure that these patients are able to access that. And this is in times of huge pressure on primary care to actually still have that bespoke what we want around patients' needs. So, like I said, hats off to colleagues in primary care for actually still keeping this going.
Yeah, so thank you. It's nice to note. Alistair?
Yeah, thanks, Jean. That's a lovely piece of work. I love the analytics and the graphics. It appeals to my love of brevity. I think some of the findings about the lack of physical checks sort of ring quite true, because there's a population of our patients really haven't seen much of, partly due to the sort of wall in between us and care homes, but also people who normally come into the clinic aren't. And I think the resurrection of COAF and the LD reviews we'll do on an annual basis can mitigate that to a certain extent. I do agree end-of-life planning is something that probably needs looking at, especially when we're dealing with a sort of more aging population of people, particularly patients with Down syndrome, where we have to sort of go into care homes and look at them. But I think it's really good work, and it's a very welcome reminder to focus on things once we regain some sense of normality. Cheers.
Well, I'll feed your comments back, because in this case, I am literally just the presenter. This work is done by colleagues across our patch, because we've got great local authority colleagues who are really passionate about this, and colleagues in our trust, as well as our reviewers who currently sit in Durham CCG, so that we can get economies of scale for it. but it's great to see. And the other thing that doesn't quite come through so much in this, but what we are seeing as well, is older patients. So according to the definition, we do all patients with a learning disability, but it's really pleasing to see older patients almost having a natural death rather than a premature death. But we're still looking for that, because you do have a legacy from early days in terms of health assessments and things like that. So it's an improving story, and it's great information that goes into services to make things better.
Okay, so thank you very much, Jean. So we consider the content of the report and definitely support the implementation of the learning and recommendations to date. So thank you very much. And it's over to you again, Jean, for the CCG annual complaints report.
Yeah, thanks again for that, Pos. So this is a report that is produced by our colleagues in NEXT, who undertake the management of complaints on behalf of the CCG. And as I say, it's covering the whole year period. I think one of the key points is that it's a breakdown only of complaints which relate directly to us as a CCG. In the NHS, just as we talked earlier on when Michelle was talking about feedback that we get through Healthwatch and feedback that Healthwatch gets through other different bodies and routes and venues, it's very helpful to know how we feel to our patients, what we do, how it lands, how it doesn't land, etc. So this report is around about complaints about the CCG. What do we do? How do we do it? And everything like that, as opposed to complaints that we receive when somebody's saying, oh, I went to such and such a hospital and I didn't like that. So when you're looking at the categories in that, please bear that in mind, because obviously our frontline services are very limited in the way that we do them. So again, lots of information in terms of grades of case around about the complaints as well. I think it's an interesting graph on page 2 at 2.3 in terms of grades of cases. And you can read that in many different ways, the way that that data goes. And we don't have a rate, which sometimes is helpful, but sometimes it makes it so small it's not much use, particularly given the last year that we've had. Lots of different categories, which I shall leave you to read at your leisure. And then under 3.1, the recommendations and service improvements from complaint investigations. And this is where we do benefit from having our NEXT colleagues do this, because although those examples underneath don't necessarily relate to our CCG, what our CCG does is get the benefit. So it's that collective learning. You know, when we talk about let's learn and let's share it wider. So let's not wait for the complaint to happen here. Let's learn from others and make sure that the improvements are embedded in our services. If my colleague Diane Murphy was here, she would speak very eloquently to the continuing healthcare, the work that consistently goes into improving that. This usually is at a very difficult time in a patient and family's life, so a lot of sensitivities and a lot of work goes into optimizing that so it's smooth, so people understand. But clearly very stressful times, so we do still get complaints around about that, and that's in keeping with the national picture. I think it's important, if you look at page 8 under the complaints process 3.2, there's something in there about continuing business as usual through COVID, because we do know that we had national direction, thou shalt do things this way, thou shalt do things that way, that you can stop this, you can suspend that, etc. But our colleagues in NEXT complaints team pulled out all the stops to actually keep that conduit going, keep that lifeline for flows of information about how it was feeling for people. So I think we probably want to say a massive thank you and record that in the notes, if I may suggest, Chair. And then also just looking at, we have the CCG, we have our NEXT colleagues, we do work as a team, but I think that little bit in there about how the complaints team worked with other teams to support the vaccination programme as well. that's an illustration of how we do work as one team for the benefit of our patients wherever we find them. So that, Chair, is my summary, if that's okay, but once again, always happy to take any feedback or questions.
Okay, thank you, Jean, and thanks noted officially as per your suggestion. Any comments or queries, Janet?
Thanks, Paz. Just to flag and raise, following off what Jean said, when some of the issues with regard to the vaccination programme came to light via a complaint route, we did actually try to locally resolve those issues where possible and actually make sure that we could try and support the individual to receive their vaccination as per their cohort for vaccination priority, to make sure that, yes, we did try and resolve it, support the individuals as best we were able to.
Okay, thank you, Janet. And Jackie?
Thanks, Chair. I just wanted to add a little bit in terms of the table that Jean highlighted with the figures, the comparative figures across the CCGs. It looks as though the Tees Valley had significantly higher complaints and concerns raised, particularly around COVID. And I just wanted to give a little bit of context around that, although it is explained in the report, I think. What we decided to do very early on was to field any queries, not necessarily concerns, but also queries that we had from patients and their families about the vaccination routes via our complaints team. And the rationale for that was to make sure that we had a consistent approach, a clear approach, but also so that we could get all of that evidence from one place and feed that up the line and into our communications with health watchers, local authorities, the FAQs on our website, and also they would be fed into the NHS England sort of like regional cell as well. So any national comms, we're getting some of the information from on the ground that we were hearing from our patients. So that's part of the reason that those figures look different, because I think we're the only CCG that have approached it in that way. So obviously those figures are then recorded by the complaints team.
Yeah, thank you.
And Chair, if I may just come in on the back of that, I think that's why it's always it's the background. So when we look at a trust that's got really high incident figures, are we worried because they've got really high incidents? Or are we really pleased because they've got a low threshold for reporting? I think, you know, from a number of years ago, a lot of national work that was done around complaints. High number of complaints can be, and often is, but not exclusively, a good indicator, because what you're doing is you're lowering your thresholds for information to come in to such an extent that it's easy for patients to feedback, it's easy for family members. It's not some sort of Herculean task that you've absolutely got to fight your way through. So it's always in the context of the organisation. And I think what Jackie's given us is a wonderful explanation how we've used an existing process that, in fairness, is well oiled. It's manned by very experienced personnel. And then we've tapped that into our information flows in terms of that continuous improvement, particularly around the vaccination programme. Because we've got various different cohorts, demographics, geographies, and we were trying to cover everybody as fast as we possibly could. So I think that feedback's really helpful. Plus it's a standardized format so that actually we can do something meaningful with it.
Yeah, absolutely, Jean. And certainly considering this was an unusual circumstance for patients and their carers to be having to go through in relation to COVID and COVID vaccination, it would have been helpful to have had a good, smooth process in place for us in the Tees Valley to handle things. So thank you, Jackie. Okay, so that's been received and noted, and thank you for the comments. And now moving on to quality and safeguarding report, and it's you, Jean, again.
Yeah, so apologies, colleagues, because you're probably tired of listening to me by now. So this is the quality and safeguarding report. The clue is in the introduction. It is a summary report by exception. It is by no means everything that we're doing in the world of quality and safeguarding. It's key points to bring to the attention of the governing body. As you would expect, the ongoing quality improvement, assurance work, challenge work takes place outside of this. It's purely an exception report. And in the traditional format, it starts off with our acute trust partners first. Under Never Events, we've talked in there about a report that's coming on improvement work. This is coming from NHS England that has now been received this week, and we look forward to looking at that and discussing that further with the Trust. In terms of the emerging themes, rather, in terms of the Loss to Follow-up Internal Risk Summit, a positive sign that the Trust has picked this up and is looking to widen its scope. So further work, but also to get that assurance. And that they're now going to use a multidisciplinary team for a task and finish group, and that will be led by the Chief Operating Officer for the Trust. However, will be informed also by clinical colleagues. Moving on to North Tees, the work around the paediatric service continues, both in terms of internal work with the Trust and improvement work, but also the links as they work with the CQC as well. One key thing, and again, it's the nuances around information. The non-invasive ventilation incidents, this has been a really positive piece of work that's been undertaken by the Trust. Some terrific learning that's come out from it. Once again, we've encouraged the Trust to share that widely, which they're doing, both across our ICP, but potentially further and wider as well. And that's going to be presented at our forthcoming quality committee as well. Moving on, Tees Valley, their CQC inspection. This was into the acute wards, inpatient wards for adults in the Trust and for their psychiatric intensive care unit. You can see the ratings there. They are also publicly available, as is the report, and clearly it's a concern. And there are some information there in terms of regulatory action that the CQC is taking around improvement and short timeframes for that. In conjunction with that, there has been a quality board put in place. Now, this is part of the quality escalation processes that the NHS has, that we fit into as a CCG, but also above and beyond us as a CCG in a regional NHS England, NHSI approach to that as well. That is chaired jointly, and that work is ongoing at the moment. And we've just been advised this morning by the Director of Nursing that the CQC are back on site. And although this is an unannounced visit, it's an expected unannounced visit. This is a traditional format. When you've had an inspection, they come back again. You know they're coming back, but you don't know when they're coming back. Anyway, they're back on site now for the next 2 to 3 days. And then the other key things I wanted to talk about, I've mentioned there under CDDFT, in terms of the routine monitoring surveillance and how that works. We are beginning to see those so the contractual flows continue, but we're beginning to see a smoothing of the flow of information because, of course, this provider works both north and into our CCG. So we are very keen that we don't burden anybody, but that we maximise the value derived from any information flows and any improvement work, so that we can share that far and wide. And I think that's probably it, Chair, because I'm conscious of Jackie and her timings, which I think is really helpful. One other thing, if I may, because we do tend to talk about things locally to our CCG, but we're not just focused on our patch. Under other information 10.1, we had some notification from our NHS screening colleagues about an issue that affected some of our patients. So again, we're working on a wider collaborative footprint to resolve that. And then under 11, we've got an international issue that NHS England were really helpful in the middle of the beginning of the vaccination programme. We did become aware of some concerns around sterility of products. Everything that should have happened did happen, and it wasn't an issue for us locally. However, the information was really helpful, so we could go and check. Thanks, Chair. I think that's enough, unless anybody's got any key points that they want to.
Okay, thank you for that. So it's a very broad-ranging report. From a point of view of general assurance to the governing body, you've flagged various bits and pieces, and particularly in areas where there are trusts going into receiving support from NHS England and then being stepped down. Can you assure us that there's a smooth process for quality monitoring and surveillance where it changes from a CCG lead to an NHS England lead and then back again, that there's a smooth process for transfer and there's no risk of any sort of gaps in monitoring in between?
Well, if I may, because we don't transfer. So just because NHSEI are leading on, for example, the quality board, it doesn't mean that we stop doing anything and we say, there you go, chaps, this is what we've been doing, you can do it now. We continue because our contract is, we are the commissioner of the services. So our contract continues, but also even if it didn't, our relationship continues. So what that means is any trust that has any challenges has the benefit of additionality. It's not just we worked with you and now we're working with somebody else. So we both continue with our work and we feed into any escalation processes and we receive information back from those escalation processes. And when the improvement is to such an extent that the de-escalation takes place, we continue with our routine work. So there isn't actually a handover. What there is in reality is a wider sharing and a greater resource to support improvement. Does that explain it better?
No, absolutely. Thank you very much. Yeah, that sort of clarifies the matter for our public colleagues. Thank you very much. Any other questions or follow-ups or queries? Because we've also got governing body members who are sort of more closely involved in the quality process here as well, if they want to flag anything at all. No? Okay, so that's been received and noted, and we've considered your report, and moving on. Yep, to governance assurance and risk report. Over to you, Jackie.
Sorry, I thought it was performance before me.
Oh, sorry, apologies. Yeah, I've jumped a line. Yep, I've scrolled too far on my list. Apologies. Thank you very much. Sorry. Over to you, Craig. Didn't mean to miss you.
It's okay. Cheers, Pos. I thought I'd escape there, but I'll give you a quick overview. I'll assume that everybody's had the opportunity to read the report, and I'll pick up any questions at the end. But just in terms of highlights, if we have a quick run through the pack, in terms of infection rates have continued to fall across the Tees Valley. The position that's reported is actually slightly out of date now, due to timing of producing the papers. So current rates range between 32 per 100,000 and 8 per 100,000 across the Tees Valley, 32 in Middlesbrough, 8 in Hartlepool. So that's a much improved position from that stated in the report. And behind that, obviously, we've got the picture on vaccines. So I won't go through that in any detail, as Janet's already alluded to the 630,000 vaccines across the patch. In terms of hospital admissions and patients in a hospital bed with COVID at the moment, the numbers have significantly improved. Back in the peak of the last wave of the pandemic, there was around 660 patients in the 3 hospitals across the Tees Valley at the peak. We're now at a position where there are 7 in Durham, 1 in North Tees and 5 in James Cook. So it's actually much improved, and that's allowing us to get back to some kind of normality in terms of our elective recovery, which is a real positive. Working further through the pattern, then the elective recovery itself, whilst we're aiming to get back to near normal levels, the report actually details the position during February and March when we were still dealing with the pandemic in its peak, really. And what that's meant is there was a shortfall in the number of planned procedures and outpatient attendances that could take place. At the moment, we're working with all 3 trusts to make sure that we get back on track as quickly as possible, with recovery trajectories looking at around 70% of elective activity taking place in April, 75% in May, 80% in June, and then up to 85% in July, before hopefully heading back towards normal levels of routine activity taking place. Clearly, that will be subject to the impact of any further waves of the pandemic, and that's why it's really important we continue to stress that it's important individuals take up the offer of the vaccine when it's available to them. In terms of some of the key performance issues that we're working to address at the moment, continuing to work on the waiting times. Waiting time positions have stabilised now, so the waiting times aren't increasing, but we do have a significant backlog. And again, that's why it's really important that we work with the acute providers to try and get the elective programs back on track so we can start eating into those backlogs. And in terms of cancer, again, it's a similar position. There are some backlogs. We're using the independent sector to try and support providing additional capacity, perhaps moving non-cancer patients out to the independent sector to protect the capacity in the acute hospitals to manage cancer patients. We're working that through the cancer cell, the Tees Valley Cancer Cell, which is looking at those patients who require priority treatment and where the capacity is to help manage that. And obviously there's further work ongoing around increasing the diagnostic capacity across the whole region. That's beyond just the Tees Valley through the Community Diagnostic Hub programme as well. So that's a whistle-stop tour through our recovery and current performance. Within the pack, we have got the appendices that details the full performance report. I wasn't going to take the meeting through that, but more than happy to answer any questions, if that's okay, Chair.
Okay, thank you, Craig. Any questions or queries? Can we just quickly sort of talk a little bit more detail about cancer and recovery? That is being sort of significantly getting attention in order to progress?
Yeah, absolutely. That's clearly a priority area, and in terms of stepping down the elective programme whilst we were managing the pandemic and the peaks of the pandemic, cancer was one of those areas where we looked to protect elective capacity. So we were still proceeding with the most critical life-saving surgeries wherever possible, and indeed some of that work was also moved out to the independent sector. But in terms of our recovery now, we're looking to prioritise those cases. There's clinical reviews being undertaken to make sure that any available capacity is being used with the right patients getting access to that treatment. There is a real push right across the entire North East and North Cumbria region, and we're working really closely with the Cancer Care Alliance to make sure that we take a really structured, organised approach across all of our populations within the North East North Cumbria, so that we can try and recover together collectively, and no patient group is disadvantaged.
Yeah, thank you. Now, sorry, Karen.
I just wondered, for those, there's obviously a lot of patients waiting for elective surgery across all the trusts. I just wondered what the communication plan is between the trusts and those patients, so they know where they are and what's happening.
Thanks, Karen. That's actually some work that's currently ongoing. So there has been clinical reviews of the waiting lists, and patients have been contacted via letter, and we're currently working through processes to understand how we can maybe offer patients alternative choices around other sites that might be able to treat them more quickly. So just working to understand how we would go about doing that. We've undertaken a small pilot contacting a number of patients on orthopaedic waiting lists to see if they would be willing or interested in accessing treatment that might be earlier than continuing to wait at the current provider. So we're just looking at what the outcome of that is and whether or not that was an effective approach that we could then roll out more widely.
Okay, thank you. Janet?
Yeah, just it may be worth me mentioning that I've been involved with initial work across the northeast North Cumbria area, looking at something called Waiting Well, to support our patients who are waiting for surgery, acknowledging that, yes, we do have large numbers waiting. It's therefore really, really important that we help them to be as fit for surgery and ready for surgery as they're able to be. And it's looking at ways that we can make sure that we've maximised their clinical surgical readiness, i.e. make sure that they're not anemic and that all the other conditions are well controlled, but also supporting patients to stop smoking if necessary, needed before their operation, doing everything that we can to make sure that those waiting are as well as they can be and as ready for surgery when we're able to get them through and to prevent any further delays, Karen. It's one of the many different streams that will help to look at support our patients so that, yes, that they're as well as they can be, but they're ready for surgery when they get the go ahead to go for it. And those programmes will be rolled out across the North East piece as we work out, which is the best approach for different specialities.
Okay, thank you, Janet. Hassan, you got a hand up?
Yeah, what Janet was pertaining to from the personalised care workstream from the council lines, rehabilitation is quite high up on the agenda of making sure that we're maximising our patients' ability to recover well from that, and also using it to decide which patients are actually suitable for surgery and further treatment. So it is something we're going to be hearing a lot more about in the coming months and years, especially from a cancer point of view.
Thanks. And from a sort of parity of esteem perspective, Craig, do you want to sort of touch on mental health and how that's progressing?
Yeah, so from a performance perspective, during the pandemic, we've actually done rather well in terms of the performance standards, but the bulk of the impact from a mental health perspective is starting to come in now. So we're seeing increased demand for services right across the full spectrum of mental health services that are provided. So I suppose the big challenge to us now is how do we manage that demand? How do we make sure we've got capacity, both in terms of some of the community and outreach services, but also in terms of demand for inpatient beds. And that's been a real challenge for our provider, Tees Esquire Valley, over recent weeks and months. So we're continuing to work collectively through what's been established in the Tees Valley. So we've got an ICP planning group where we bring together members of the local authorities, public health, commissioning from healthcare, i.e. the CCG, acute providers, mental health providers and the ambulance service to look at what are the alternative options for treatment, early access to services, etc. How do we further stretch our capacity and broaden the offer of access to services so that the whole population can access services equitably, and we don't widen any of the inequalities that were previously in play.
Okay, thank you, Craig. Janet, is that a residual hand?
Well, I'm sorry, it was a new one. I was quickly pause if I can, just following on from what's already been said. It's really, really important from a health and wellbeing perspective. We've mentioned about how busy hospitals and primary care services are, and it's what we're doing to support our staff through what has obviously been a difficult and challenging time. We've talked about the CCG responses from a health and wellbeing point of view, and indeed, yes, there are significant steps in all the provider trusts and in primary care to actually support our workforce to make sure that we are doing what we can to support their health and wellbeing, to enable them to be well enough to remain at work, obviously, but also to make sure that it prevents more people becoming more unwell, and also in the primary care perspective, actually encouraging patients to self-care and self-refer on where they're able to do so to the many means of support within our mental health support services in the voluntary care sector as well, from a broader wellbeing perspective, in addition to mental health services provided centrally.
Thank you, Janet. Points well made. Okay, so thank you, Craig. Your report is received and noted, and performance noted. Thank you very much. Okay, apologies. This time over to you properly, Jackie.
Okay, thank you, Chair. Just a few things to draw out from the usual report that you receive. The first one there is about recognising the efforts of our staff. We've heard a few times this afternoon about the sterling work that has gone on throughout the organisation over the past year. And in common with other CCGs across the patch, the Remuneration Committee were keen to award staff 1 day's additional leave to be taken this year. So that's there first and foremost, which draws together some of the things that have been raised earlier on in the meeting. So we would ask non-conflicted members, so certainly lay members and the GPs, if they could ratify that proposal, please. Moving on to the risk update at section 3, there have been 2 key developments really to draw to the governing body's attention, one of which clearly you're aware of in terms of the work that we've been doing in the development sessions for the risk appetite, and the final risk appetite statements are provided at Appendix 1. Then a new area of development is, as we're starting to look towards greater system working, the establishment of the ICS as a statutory body. and the impetus that has given some of us governance leads just to actually look across how we manage and record risks across all of our organisations. And it transpired that there were actually different ways of scoring risks. The majority of CCGs did do it the same way, but there were a couple of CCGs that had tweaked the matrix as time moved on. Obviously, that was appropriate for their organisations at the time. So what we have looked to do is adopt a common risk matrix for scoring, and that is based on NHS England's improvements matrix that they launched not too long ago. And that also gave some common descriptors of risks materialising, so the likelihood element of it, and I've included those in the report. I've also provided an appendix, and Appendix 2 shows what the revised risk profile would look like and compares it to the one that you're used to seeing. And you can see that the shift between the red, amber, yellow and green. In the work that I'll be doing with directors over the coming weeks as we talk about risks relating to corporate objectives, we'll also just look at their existing risks and make sure that the scoring still seems to be appropriate. So when you see the next iteration of the risk register and assurance framework in July, it should be fully refreshed. Moving on from that, there's some additional work being undertaken by NEX on behalf of all of the CCGs to compare risk registers a little bit more closely and see where there are any gaps, any common themes, any really key differences, so that we've got a bit of a heads up on that as we're moving forward. Review of effectiveness, I'll skip over. We've talked about that in the development sessions, and that's more of the operational processes behind the running of the governing body and committees. And then finally at section 5 on page 214, we've got a bit there about keeping our staff safe and secure. Julie mentioned something in the staff survey section, and Janet has just mentioned as well about looking after the well-being of our staff. This is something that we've been doing throughout the pandemic in terms of doing risk assessments, having health and well-being conversations with staff, really trying to make sure that they're in as good a place as we can help them to be in. That's also included us having the CCG offices remain open and COVID secure for those staff who need to work from the office in exceptional circumstances. It hasn't always been appropriate for the working from home. So where they've had to do that, we've been able to help them to do that. And as we start to prepare for the potential easing of the work from home where you can message, we're linking in with our HR and health and safety teams to make sure that obviously we take all the necessary steps to make that safe transition back to the office. And that's from a estates and facilities point of view in terms of making sure it meets all of the guidelines, but also in having those conversations with staff to see how they feel, because one size certainly won't fit all. So there's that short-term bit in terms of returning to the office post-COVID, but that helps us build on the work that we'd started quite a while ago, pre-COVID, in terms of what we previously referred to as agile working, but it's now referred to as hybrid working, where we can offer more flexibility to staff to help in terms of their well-being, work-life balance, and the business needs of the organisation. So those were the key areas that I wanted to draw out of the report.
Okay, so thank you very much. Any questions or comments? So we receive the report and note the updates. We're asked to approve the recommendation for the 1 extra day of leave, which I strongly suspect actually probably doesn't really reflect the sort of time extra that our staff have been spending on the COVID response. So everybody happy to approve that recommendation? Yeah, there's nods around the virtual room. And we note the rest of the report. The one thing to flag from my perspective is that our biggest residual risk with a rating of 20 down, that hasn't changed from a red, is the risk from COVID impacting on the work of the CCG. And we just sort of wait to see how things play out at the moment with the Indian variant, as noted earlier in my chair's report. So thank you very much for that, Jackie. Moving on. So we've got some items for information. There's a special education needs and disabilities assurance report there present for information, unless anybody wants to ask anything or comment on that. No. Okay, and then we've got some reports from committee chairs. So Audit and Assurance Committee. Karen, I don't know if there's anything you want to flag from that, or it's just there for information. For information. Executive Committee, Dave, anything for you to flag from that at all, from the report?
Probably just a general comment rather than anything on the report. I'll happy to take any questions on it, Paul. And it's just a reflection we probably need to put on the record that when we receive reports like this that are from other committees, because of the time it takes them to go through committees, some of the information is correct at the time, but will have changed over time. So just so everybody's aware of that, probably more a message to public that attend our meetings to recognise that some of the reports there are going back to February and earlier. The information was right at the time, but obviously things will have changed as things have moved on.
Yeah. So note the timing of the original report and the potential for things to have moved on, particularly in this last year of unusual circumstances. Okay, Primary Care Commissioning Committee, Caroline, anything to flag from that? No.
No, nothing.
And Quality Committee, Andy, anything for you to flag from that?
Just to say, it was been an interesting time. We've transferred from QPF to a quality focus, and then we got stood down because of the reducing the burden agenda. So it's been a bit of a roller coaster, but I think we're back on track, and I think it's going to look good. It's going to deliver some good outcomes as we move forward.
Yeah. Okay, so those reports are noted. Then there's the CCG committee's annual reports. I don't intend to sort of go through them in detail. Executive Committee, Primary Care Committee and Quality Committee, they're there for noting. Nobody's raising any hands or anything of issue to note there. CCG minutes received, various committees that you can see there, Audit, Executive, Primary Care and Quality. We'll receive those or note those, okay, for information. The Northern CCG Joint Committee, most recent one from the 11th of March, noted for your received there to be noted for your information. I haven't received any other business notified. Anybody got any other business, particularly Dave, Jean or Janet or Karen, Craig? No. Okay, moving on. Okay, so Nick, Marco, this is your opportunity. Thank you very much for staying on with us. Anything you want to, I haven't had any pre-noted questions. Anything you want to flag and query at all?
No questions from me, thanks. It was just I just wanted to have a bit of a general update, see how everything's going with COVID. But yeah, good to hear how the recovery process is going. I think in that report especially covered everything.
From your perspective, have we successfully managed to avoid over excessive use of NHS jargon or abbreviations?
Yeah, definitely. Yeah, I think there's barely any at all through the meeting. That maybe it's just a sign I've been to too many health meetings, but yeah.
Okay, thank you very much. And any considerations, any impact on the risk register? We actually sort of talked about the risk register in a little bit of detail just now. Jackie, anything that you figure that we should be flagging for the risk register at all? Nothing to leap to my mind.
Not from the conversations that we've had. We need to have a few conversations internally to make sure that the risk register is fully reflective of the new corporate objectives. So.
Okay, so thank you very much. Thank you for attending. Apologies for my inadvertent errors where items slipped up past the edge of my window on the screen. So thank you very much for attending. We've managed to hit pretty close to our planned running time, in fact slightly early. But that's thanks to Jackie for having noted previously from earlier meetings our lengths of running time on various items previously. So it's better to actually run slightly shorter than run significantly longer. So I'll close the meeting on that basis. Thanks very much for attending, and have a good weekend coming up. It's supposed to be a relatively sunny and mild bank holiday weekend. Fingers crossed, you know, pigs might fly, but this is a bank holiday weekend coming up, so enjoy, folks. Thank you very much.
Thanks very much.
Bye.
Thanks. Bye.
Bye, folks. Bye.
Bye.